Who are the candidates for Durysta? Well, if we look at the phase 3 studies and we look at the FDA approval, we can see that Durysta can be used on patients who have ocular hypertension or glaucoma, patients with any level of severity of glaucoma, patients who are on 0 drops, 1 drop, 2 drops, 3 drops, any number of drops. In a clinical study, we saw Durysta being used in 3/4 of phakic patients and 1/4 of pseudophakic patients. I expect in clinical practice, we have so many pseudophakic patients, and there really is no better candidate for Durysta than a pseudophakic with a healthy endothelium. There's plenty of room for the implant, and we don't need to worry as much about the corneal endothelium because if they've safely had cataract surgery, there are no major stress tests for that cornea ahead of the patient. We can be a little bit more comfortable. We really know that patients with compliance troubles are going to benefit the most from Durysta because patients with poor compliance are untreated glaucoma patients, and untreated glaucoma leads to blindness. Dry eye syndrome is associated with eye drops, irritation, redness. That's meibomian gland disease. It's corneal staining. We know that can be caused by the preservatives. We know it can be caused by the active ingredients. When we use Durysta, we eliminate all of those variables. We take the equivalent of 1 single drop of imatropros 0.03. We put it into 1 implant, we place that right at the target tissue inside of the eye, and we should eliminate a lot of problems related to the toxicity of the drops and the preservatives themselves. I know that patients who take many drops will have trouble keeping them straight, and they'll have trouble taking them all. And eliminating one of those drops, as we would do when we give Durysta, can immediately make things easier. But I'm also hearing from a lot of my colleagues that when they give Durysta to a patient who's on 4 drops, they're often able to stop more than just 1 drop, sometimes 2, sometimes more. Finally, we know that patients who have undergone SLT have typically undergone SLT laser for a reason. They had tolerability problems, they had compliance problems, they didn't want to take medications. Those patients, once the SLT has done its job, but if it is worn off and they've had several treatments, may be better to switch them over to sustained delivery because they can have a different approach and not have to have multiple laser treatments, which in some cases will lead to the pressure going a little bit higher. When I talk to patients about Durysta, I try to tie it to their problems, and I do that so that they understand I'm bringing this medicine to them to make their life better, to address something they've told me about. And I think that's really important for me and is really important for patients. We aren't pushing anything on them. We're trying to help them solve patients, but we've got to use our knowledge and experience. We're the ones who know that drops make eyes red, that drops make eyes itch, that drops irritate the eyes, that people forget to take their drops, that they may be in denial of the fact that they're not taking their drops. We've got to use our expertise to show our patients how we can help them solve their problem. One problem that can be a little bit more difficult to discuss with patients that I'd like to cover is the current FDA approval for just a single injection. When Allergan, we know, initially developed Durysta, they were imagining that it might be given every 4 months on an ongoing basis. And one of the things that they learned in their clinical studies is that 3 injections over 1 year is probably more than you need, and is probably more implants than the eye wants to have at a given time. The Durysta implant lasts between 1 and 2 years, and it shrinks considerably after 6 months. So what's the ideal dosing? Well, the FDA is waiting for data on that. Allergan has 5 ongoing studies, and so once those studies have produced data, that will be presented to the FDA, and there will likely be some revision of the current indication that says only give 1 injection. But what I tell my patients is, first of all, the one thing we'll get out of this is a break from the medicines you're on. We may learn something about your eyes, we may learn about dryness or what's causing your problems, and then you'll get some relief. 2 is that we learned from the phase 1-2 studies that some patients last up to a year with just 1 injection, and that's a quarter of patients, and we saw at every level, 6 months, 9 months, a meaningful fraction of patients were making it without any other therapy with just 1 implant. So you could have a patient who does really well with 1 implant. You want to take advantage of that. But finally, for me, I do expect that we will have a different FDA indication far into the future, more than a year from now. And what will we expect? Well, it may say 1 injection per year for several years, it may say 1 injection on a treat and extend PRN basis. In either case, I believe that patients who've received their first injection will be that much further along, because we know that with multiple injections, the proportions of patients who are able to go a full year without therapy will increase. And I think our patients will be trying to get access to that mechanism we believe is going on, remodeling of the uveoscleral outflow pathway, that will ultimately allow the patient to get a year or maybe even longer without any topical therapy. Finally, there are some other things that we want to talk to our patients about. Interestingly, telling patients that this is an insurance benefit and that we have to check their insurance has led to some nice conversations for me between patients. Patients are happy to hear that their insurance is going to cover a new therapy that I really believe in. I'm always excited to share that news with patients. And the insurance coverage, has been encouraging, and in many ways more encouraging than looking for insurance coverage to some of the newer glaucoma topical therapies. And then the final thing that I like to do for my patients is let them know a little bit what they're missing out on. And by that, I mean share the positive experience my other patients have had with them. I've had patients who have had the injection and can't believe I gave them the injection. They didn't feel a thing. Their vision's perfect. That's it. Can we do the other eye today? Well, I was going to wait till next week. And then patients coming back, not on therapies, their eyes are feeling better, they're seeing better, their eyes look better, so they're looking better. They're very thankful to me. And I think letting our patients know what the journey may lie ahead for them, getting their mind off the injection, but onto the life they could be living free of drops, very meaningful way to bring this home for patients. Ultimately, we believe in this therapy. We believe that doctors treating glaucoma with a reliable and sustained therapy is ideal. We want to share that belief and conviction with our patients and ultimately help them come to the right decision to have this new therapy that has very promising results for the future of glaucoma. Thank you very much.